Good afternoon, and welcome to this new session on inpatient care, something that has actually been near and dear to my heart for I don't want to say how many years. So we have three sessions this afternoon. Each speaker will have up to 15 minutes and then questions afterwards. So we actually should have enough time for all the talks and enough time for a good discussion moving forward. So I'd just like to, the first talk, intravenous fentanyl for symptom management in hospitalized patients with refractory opioid management, a retrospective cohort, and Julie is going to be speaking for the team. Thank you.
Thank you. Hi, I'm Julia Zaslina, and I'm a addiction medicine physician. I work at St. Paul's Hospital in downtown Vancouver, and I'm also a general internist. And this study was done at St. Paul's. So none of the authors have any conflicts of interest to disclose. So I don't think I need to tell anybody in this room that the number of opioid-associated deaths and drug poisonings in Canada is absolutely staggering. And a lot of this is attributable to the increasingly potent and toxic drug supply. And of course, in hospital, especially in patients that are admitted in order to receive medical care for a variety of other reasons, we are finding that there are more and more individuals that are refractory to traditional methods of managing their withdrawal. And as a result, at St. Paul's, there have been occasions where we have started using IV fentanyl on the ward to support these patients. However, obviously there's little data on this, and we wanted to find out a bit more about this population, to characterize them. When are we using it? Why are we using it? As well as to look at things like what approach is being used, what types of doses are being used, and some of these substance use related outcomes. So this is a retrospective cohort study, and it was dated from November 2019 to December 2021. And it was done via chart review. So for inclusion criteria, patients had to be at least 18 years old, have a diagnosis of opioid use disorder, and they had to be prescribed IV bolus doses of fentanyl of at least 200 mics at a time. This had to be prescribed by the addiction medicine consult team, so it couldn't be like through palliative care or anesthesia, anything like that. People were excluded if they ended up coming to hospital and being discharged within 24 hours, or if they were prescribed the fentanyl but ultimately never received it. So this accounted to a total of 89 encounters over that period, 59 of which we were able to include, and this consisted of 43 unique individuals. So as you can see, there were a number of people that were actually admitted on multiple occasions and received the intervention multiple times. So men made up 56% of the patient population, and the average age was 42 years. As you might have guessed, the vast majority of people were admitted under either the internal medicine service or our urban health service, which is generally staffed by infectious disease for complex infections. The remainder were kind of a smattering of other services, orthopedics, psychiatry, palliative care, and so on. The population was overall quite complex, and one of the markers of that was the number of other substance use disorders that they had. Amphetamine use disorder in 74%, and I'd also draw your attention to the sedative or hypnotic use disorder, which was predominantly benzodiazepines, and some of that was people that were seeking out benzodiazepines independently of opioids, and others that were demonstrating concerning benzodiazepine withdrawal due to contaminated supply. This was a group that had a large number of people that were just on no form of medication for their opioid use disorder at presentation. So 40% of people were basically coming in untreated. And when we look at the types of treatment that the people that were receiving it had, which accounted for a total of 60%, and about 49% of them had just kind of either, and the reason I say medication for opioid use disorder instead of out is that this also included people that were receiving things like fentanyl patches or extended release like 12-hour hydromorphone, 12-hour morphine, things that were kind of off-label and not really considered within the category of OAT. So that's why that's generalized there. So about 50% of people ultimately, both within first presentation and all encounters, were on some form of treatment like that. And an additional kind of 12 to 14% were actually on injectable opioid agonist therapy in the community, typically diacetylmorphine or IV hydromorphone. And there were a large number of previous attempts that people had that had been documented. So we counted a previous attempt as if it had been mentioned in the addiction medicine consult notes at any point that they had previously been on like methadone, sustained release oral morphine, so on. And that probably means that we included people, because if it wasn't explicitly mentioned as having been at trial, it was counted as no. And despite that, we can still see that this was a group that had a large number of treatment attempts in the past. And again, some other markers that reflect the complexity of the population. A very large number of people had no fixed address, and like approximately a third. And there were a large number that also had an admission for the same medical issue in the previous month. So this speaks to the fact that this was probably a group that was self-discharging from hospital, not completing their treatment, and then representing again. So part of what was motivating this intervention to be provided was retention in hospital to complete treatment. And I think that this is one piece that's reflective of that. Most of the time, the most responsible diagnosis at the time of discharge was infection. In terms of their use patterns, so people were using a median of 1.6 grams of fentanyl a day, but the range was quite dramatic, anywhere from 0.25 to 9 grams daily. 93% mentioned that they were using via parenteral route, which would make sense considering that the intervention was the IV formulation. Fentanyl dosing. So this is interesting. It varied very dramatically. So anywhere from 250 micrograms on the lower end. You might remember that our cutoff for what we picked up on the study was 200. So that kind of fits. But it ranged as high as 5,000 mics for a single dose. And this was typically dosed every 1 or 2 hours as needed. So this was administered by nursing staff on the ward. So this isn't like an HAU, ICU monitored setting. This is like a push dose by nursing on the unit. Yeah, it's a lot kind of shocking, I think, for anybody who has intubated anyone. Yeah, so basically when we kind of look at trying to break that data down and figuring out like, okay, so what are most people getting most of the time? The most common dose was 1,000 mics every 1 or 2 hours as needed. And when we look at the maximum any one patient received in 24 hours, it was 27,000 micrograms. And the median kind of maximum dose was 6,000. But as you can see, that was like a pretty big range there as well. People were treated for a median of 9 days, but this ranged really quite widely, anywhere from 1 to up to 43 days of receiving this treatment. And one thing that is, I think, a very good piece is that all but one patient were concurrently titrated on a longer acting, more sustainable form of treatment for their opioid use disorder. So, of course, we also wanted to look at what some safety indicators were. So initially we had thought that if we had the dose of the fentanyl be sort of held or reduced or discontinued, that might mean that the person was having adverse effects and that's why it was being discontinued. But actually it really seemed like it was much more often stopped because the patient either stabilized on other treatment or just wasn't accessing the intervention anymore. I'll break down the next piece a little bit more. So when we looked at, or actually, I'll go back to this part first. The naloxone before fentanyl was being prescribed. You can see that there's 4 cases in the first presentation group and 7 cases in all encounters. And this is actually often the reason that the fentanyl IV was started in the first place, was because people were using their own unregulated supply and overdosing. So when we look at opioid toxicity, and we included this like pretty generously, so pretty much anything in that category that went from excessive drowsiness all the way to requiring naloxone. And when we look at the 5 encounters where naloxone was required, All of these patients were also accessing their own supply of fentanyl on the same day as when they required the naloxone. In fact, I believe 4 of these actually occurred at the overdose prevention site on site at St. Paul's Hospital, so they received intervention quite rapidly. Again, in terms of the excessive drowsiness, there were 4 cases that had that. So this basically meant more frequent vitals on the ward, didn't require anything in addition to that. And 2 patients had myoclonus. And interestingly, they were both receiving IV hydromorphone at the same time, which, yes, is a bit odd. But when the IV hydromorphone was stopped, the myoclonus resolved. So how did things kind of end at the time of patient's discharge? So in terms of receiving a prescription for treatment for opioid use disorder, 80% of people received a prescription. In terms of those who didn't, breaking that down, 1 was a patient that had been deceased, 1 was just readmitted within 24 hours and therefore didn't need a prescription, and 11 were self-discharged from hospital with no opportunity to receive a prescription. And then we might be thinking, what about like planned discharges versus self-discharges? So looking at planned discharge, 61% left hospital via planned controlled discharge, and 37% basically left self-discharging from hospital. And it's kind of interesting trying to compare that to, like, is that a high number? Is that not a high number? But when we look at one study, I tried to find something that was comparable specifically to the population at St. Paul's. The most recent data that had been published on that was back in 2015, and that quoted a rate of 43% of self-discharges. And this is in all patients who use drugs, so not specific to a high-risk population who's using IV and before the era of fentanyl. And we're still a little bit less than that. So for what that's worth, obviously not directly comparable. So in summary, this is a highly select and complex inpatient population with a high prevalence of other substance use disorders and numerous previous attempts at other forms of treatment. They had a large number of individuals with insecure housing and many people who had been admitted with the same previous issue in the preceding month. The fentanyl dosing that had been used was most commonly 1,000 mics an hour and every 1 or 2 hours as needed. There were no transfers to HAU or ICU, and the other issues were overall manageable in an experienced monitored setting. So 80% left with treatment for their opioid use disorder, and 37% did self-discharge. So what can we kind of take away from that? IV fentanyl for refractory opioid withdrawal could be considered for some patients to support stabilization on MOUD and retention in hospital. But a setting with provider and nursing experience is crucial to optimize patient safety. The end. Mm-hmm.
Did you start with, and did you start with lower doses, kind of maybe pursuing this cohort, or was it 1,000?
No, so it wasn't the starting for these patients, it was the most common dose that was prescribed. So if you looked overall over the course of the prescriptions that any of the patients had, that was just the most frequently used dose that most people ultimately ended up being titrated to and stabilized at. But people were usually starting at around 250 mics for initial doses. In terms of the training for the nurses, there was a period of time where it was only being done on like 8A, which is the urban health unit, high prevalence of substance use patients there, effectively exclusively and typically complex infections. So nurses there were just much more comfortable with management of complicated withdrawal. And I do think that there had been some training that happened and like recurrent training, especially of other units in the hospital, because it did ultimately get spread to the point where now it's done on multiple other floors. Yeah. Yep. Excellent question. And I have a very, very long table of this in Excel. um, it was a wide variety of very different types of medications. So there were some people that were discharged on methadone, some people were on sustained release oral morphine. One person actually went home on Suboxone. There were a number of people that ultimately ended up being transitioned to IOT. There had been many fentanyl patches actually. So that was quite a common transition, is that after people had been responding well to the IV fentanyl, they were kind of concurrently up titrated on the fentanyl patch and then transitioned to a community program that could support that. Yeah, so there were quite a few kind of off-label or novel methods ultimately attempted to stabilize patients. Yeah. I don't. Yeah. Yes. So I'm not sure don't know that I can tell you the exact numbers for the exact people in this study, because this is kind of looking back at that point. I think I have that information, but I don't have it physically on me. If I recall correctly, people are typically stabilizing at around 800, sometimes up to 1,000 mics per hour. Yeah, but I can't tell you the exact number. Yeah. Yes. Yeah, so definitely the patient population that ended up receiving the treatment were those that had infections that typically required like a long course of IV antibiotics. So exactly what you're mentioning in terms of infective endocarditis, osteomyelitis, those types of pictures were sort of the most common. Often up front, if someone was like more septic, more acutely unwell, it wasn't the type of intervention that was started at the beginning, obviously. So when someone was sort of stabilized, then that was kind of considered as a retention in hospital plan, especially if someone was like continuing to access their own unregulated supply, overdosing and so on. In terms of the amount of hydromorphone that was kind of being used, I don't know that I can give you like a direct comparison to the fentanyl, but typically the doses that these people were on prior to starting this the fentanyl IV was like up to 32 or even 40 milligrams PO, like Q1 or 2. Yeah. Yeah, and we did try IV in some of them. In fact, one of the things that I actually captured was why IV hydromorphone was not used. But in the limits of today's presentation, I didn't discuss that. Yeah. Mhm.
One more question.
Yeah. Yes. Yeah. So, I mean, I hope so. I submitted it. So I'm waiting to hear back. But yeah, it's been submitted for publication. Yeah. 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 Thank you. Thanks.
Thank you. Oops. Just wait.
Very strange.
Good. I always worry when the IT guy says that's very strange, but anyway. I'd like to introduce the next talk. The next talk is something absolutely near and dear to my heart, no pun intended. The Second Heart Program, a peer-focused multidisciplinary endocarditis team for people who inject drugs. And Dr. Leslie Martin and Marcy.
Thank you. Hi, everyone. Thank you for.
Wireless mic.
Oh, wonderful. Thank you for having us here today. We are pinch hitting for some of our colleagues that asked us to come and present. So the slides are not ours, but we were involved in this project, and it's also near and dear to our heart. So I'm Leslie Martin. I'm a general internist here at McMaster, and I will let Marcy introduce herself.
I am Marcy McElveen, Program Director for HamSmart, and also now working with the Substance Use Service Team.
So we'll be sharing with you today some experiences that we learned through this initiative that was rolled out here in Hamilton several years ago and ran through the pandemic, and some lessons learned in our attempt to improve wraparound care for this patient population. I think everybody in this room is probably very familiar with infective endocarditis and what risk it poses to our patients. And as you're aware, it's an infection predominantly of the heart valves. And for individuals who do inject drugs, it's estimated to be responsible for about 5 to 10% of death in this patient population. So it has high morbidity as well as mortality. And we know that rates of infective endocarditis are increasing amongst our patient population. I'm trained in general internal medicine prior to the opioid crisis, and I actually used to see very few cases when I'd be on call after hours. And now I take care of our training program here in Hamilton, and my residents see probably 1 to 2 cases presenting every night. So this is bread and butter internal medicine now, and it wasn't actually when I was in training. I just learned recently that I'm mid-career. So when I was not mid-career, I was not seeing it. And while while similarly in the short term, patients or people who use drugs or inject drugs have relatively similar inpatient hospital mortalities associated with this condition, there's been studies that show really quite terrible mortality rates that rise over time throughout their trajectory of illness. So it's a really important problem. And so a lot of times some of our challenges that we face when caring for these patients is reinfection due to ongoing use of injection drugs. And what the literature base would show is that many patients, when they are accessing care, are not getting offered evidence-based care for their substance use disorder, which is often driving their primary presentation. And we also know that this particular patient population is lacking access to social supports, coming from a lower socioeconomic status. And so how do we really work to wrap around care for this high-risk population to hopefully eventually have an impact on mortality and long-term outcomes, as well as engaging our surgical services and our other collaborative services to improve their outcomes from a medical standpoint. So I'll let Marcy chat about our intervention.
I'll do my best. Can you flick?
I'll flick for you.
All right, we're flick. So Second Heart team is made up of people like myself, peer support workers. I think there was 4 in total at the beginning. A systems navigator who helped people connect with like getting taxes and trying to get into shelter or housing, which if you know Hamilton, you know that that's not always possible. A family physician and an addictions medicine physician to provide support for 1 year after hospitalization. So a peer worker, I can talk most about that. That was my role. So we simply connected with people in hospital, out of hospital, and just got to know them and got to build trust and helped advocate for them and build pretty solid relationships. I still talk to probably 4 people that I met through Second Heart, all at different stages. And it was never talking about like, you need to get better, you need to stop using, you're sick because you use drugs. It was just like, hey man, how are you? And having that and building that trust and just being a person they can trust that's not going to come to them with interventions or solutions and just let them be who they are. We hear a lot at conferences about meeting people where they're at. And I think with this program, even like the physicians, as much as they could, because they're physicians and you have to give interventions. Leslie's making faces at me. It's true, you do. But the peers could just meet people where they're at without making them go anywhere else, right? Like actually genuinely meeting somewhere where they're at, not expecting them to be somewhere else. And we met like, really quick, it says on the bottom there, we met like once a month. Sometimes I talked to some people every day that were in like transitional beds. Systems navigator, I already kind of talked about like helping people get ID, helping people get like, go to food banks, get housing supports, income supports. They help fill out ODSP things or get people to ODSP income clinic that happens monthly. And they met every 2 weeks for the first 3 months. Sometimes you'll see when we learn about like lessons learned and stuff that they didn't always get to connect that often. I'll let Leslie just tell what the doctors did.
Sure. So many of our patients, and you'll see this on the next slide, were not connected with primary care providers. And so one part of the program here, and we have many family physicians on our team, is that we would find them a family physician. Sometimes that would actually mean one of our team members actually picking up the patient in order to facilitate that, with the goal of being seen within 2 weeks post-discharge. And then it was not a mandatory. None of the elements were mandatory for individuals, although for the most part they were interested in all of the elements that were offered as part of this package. But an inpatient substance use consult was offered with one of our physicians on the inpatient team, and then with the goal of transitioning them to outpatient providers as well at the time of discharge. And so much of this had to do with interest in initiating opioid agonist therapy during their hospitalization.
All right, so people got money. If we are not using people, but doing research and studies, you want to give people value for what they're doing. A lot of our folks, as we said before, were deprived of housing, precariously housed, or experiencing poverty. So I think it's every 4 months, so $50 5 times. So however that works in the 12, I'm not good at math, that's why I'm not a doctor. Participants also received a smartphone. So in order to be connected to people, to their doctors, to peers, to everybody, we just gave them a phone, paid for it for the year. Sometimes 2 phones, and just trying to give them stuff they need to like social determinants of health, right? Like do what we can to meet them where they're at and give them what they need to have wellness, not just in relation to their physical health.
Yes, and this hasn't been said yet, but this was funded through a HASO grant here in Hamilton. So by linking this to research was how we were able to, within the grant, build in some of the remuneration for our participants, as well as the funding for the cell phones, because obviously that's probably a question that you guys will have. How did you get them cell phones? And sometimes they would go missing, and then we would replace them.
That's you.
That's me. Okay. So one of the greatest challenges of this was actually recruitment. So we ran this study for, I think, about 2 years in total, and we were only able to recruit 21 patients, which we actually had been tracking as a substance use service, our volume of referrals for different types of medical comorbidities, and we were able to show that this was quite an underrepresentation of the individuals that we were seeing. The main barrier to this, it doesn't say it in the slide, was actually that we're a referral center from a lot of our region in Hamilton for individuals that require surgical intervention for infective endocarditis. So our service would see a lot of those individuals, but one of the inclusion criteria for the study was, in order for our peers to connect with you and our social navigators to connect with you, you need to be geographically situated within our region. And so we did lose a lot of individuals that were from Brantford, for example, the Niagara region. We see a ton of patients from that catchment area, but they get their procedures and they go back, and we weren't able to include them. So it was one of the challenges that we faced in our program. So 21 patients were approached and 20 consented to enroll. So a really good acceptance rate, which I don't think is a surprise to anybody here. And of those that enrolled, we had 60% that continued in the program at the 1-year mark, 35% being lost to follow-up, and one passing, unfortunately, due to complications of their infective endocarditis.
So I guess I'm going to read it because I don't remember it all off by heart. But like I said earlier, majority are unhoused, about 70% were unhoused, 10% precariously housed, like couch surfing, friends, and transitional housing programs, which aren't necessarily housing because it's a transitional temporary thing. 95% unemployed, 85% receiving social assistance, which means obviously 10% don't have income of any kind. So helping them with the systems navigation and getting them connected with OW or ODSP was a huge step in like helping them with just outside stuff away from their healthcare. 50% had a primary care provider, and 15 had a visit in a year before hospitalization. So big numbers, like it's, I guess, not enough to have a doctor and not see them. Like there's barriers to like accessing that care. And 95% of people used non-prescribed opiates. So fentanyl was the most commonly used. Others were on OAT prior hospitalization. One was on, I forgot, they changed the name of safer supply to prescribed alternatives by the federal government. So prior to admission, there was only one person on, and then 1/3 of participants had experienced an overdose in 3 months prior. 100% of people were seen by the substance use service team, so that is a lot. 95% with opiate use disorder were prescribed OAT at discharge, and it's up there. What is SROM?
Sustained release or
okay.
Yeah. So
I don't know. Yeah.
So only 20% were on OAT, were on OAT at the time of being seen by the program, and 95% at the time of discharge. So a huge increase in getting people engaged in treatment.
And then of that 95, 75 had a outpatient visit. Okay, I'm not good with stats and numbers. If anybody knows me knows stats and numbers aren't my thing. I'm like a qualitative kind of person. I like telling stories. So 9.5 5 visits. So that's like pretty frequently compared to the visits with other folks in the program, right? Like we were able to connect with people in ways and times that weren't always manageable. It wasn't about making appointments. Like I would get calls at random hours. People that know me also know I don't have good boundaries. So I would like just go at like 2 in the morning and see people because they needed to be seen.
Yeah, so certainly our peer program was the most accessed by all of our participants, in part because of how accessible and wonderful Marcy is.
80% of people were seen with infectious disease during their study period, so over the year. And some of that is also because like in hospital, they would possibly leave before ID could see them. 80% had an ID consultation, so it's the same number. What was the confusing thing you were talking about?
Yeah, I thought it was a little strange that more hadn't seen infectious disease, especially because one of our several of our inpatient substance use service providers are infectious disease specialists and are linked to this program, so they could even see them in the outpatient environment. Like they would, this is one of the things that this program really opened the doors for us, is how do we get all of the providers that we need to the patient rather than asking the patient to go to those providers. And with the benefit in infective enteritis of having multidisciplinary care, cardiac surgery, cardiologists, infectious disease specialists, substance use providers, that was a real benefit of having a centralized access point. So this was a little bit surprising to me because a lot of the places where they're going to access some of these services after they left would have given them access to these providers as well.
And a big thing on the bottom there where it said 50% seen ID like outpatient, 40% of that 50%, or 40% of those people came to HamSmart for that service, which is pretty amazing. 40% of patients had cardiovascular surgery and 25% received. So I guess some had a consultation, the others actually had surgery. I can read. 75% had a cardiology consultation, most while inpatient.
Yeah. And so this has been a project. We actually had collaborators of our cardiovascular surgery department on this project. And so I don't know, again, for others, what your centers are like, but sometimes advocating for surgery for this patient population can be challenging because the surgeons are reticent to offer it until they feel the patient has stabilized and the risk of relapse is low, which can never be guaranteed. So by integrating our cardiovascular surgery team into this, we had some individuals that were basically co-advocating with us for surgery for this patient population when it was indicated. So 25% is actually not a bad surgical rate for this group.
And one cool thing, I think it might be on a slide upcoming, but I'm just going to say it now, is there's a cardiologist that comes to see those folks at HamSmart. I think it's every 1 or 2 months on a Tuesday afternoon. We'll come and do like bedside stuff at our drop-in clinic, which is pretty amazing. You go.
Okay. And so over the 12-month study period, we had 2 reinfections in our patient population. 1 death, as I mentioned, unfortunately, due to complications of the infective enteritis. And it remained a high-risk patient population. 85% had to reaccess care through the emergency department, and 55% required a hospital readmission. So despite our efforts and our wraparound care, them accessing their peer support workers pretty well, accessing the social navigator not badly, all of them being connected with a substance use provider. We don't have a pre-risk, but their risk remained very high. So what did we learn from this? I think we learned actually quite a bit. We really focused on the fact that a multidisciplinary approach to care was deemed both acceptable and feasible by our participants and our care providers, who actually continue to provide care, as Marcy said, despite the fact that this pilot has closed. And early engagement with the team was critical. So we would, as makes sense, if you don't have this all set up before discharge, it becomes a lot harder to follow up with those individuals and to make sure that you have a care plan in place. So as the project went on, we started to change our methods a little bit and pull together case conferences with all of the individuals involved early so that whenever discharge was ready, it wasn't a panic to suddenly try to get together this multidisciplinary team. And
including patients in like those case meetings instead of having them and then talking to the patient after.
Exactly. And our peer support workers in substance use care was the most highly utilized as part of the intervention. As we mentioned, many of the social determinants of health were the biggest barriers for our patients' housing crisis, lack of access to stable housing, poverty, stigma, ongoing toxicity of the drug supply continue to threaten the outcomes of our patients. I think the biggest thing, and I know there was a recent publication in, I think it was the New England Journal of Medicine, looking at like community-based interventions and whether they could see impact on mortality, and they weren't able to demonstrate that despite, many different interventions. And I think this is another place where we don't have mortality data to say that this necessarily, it was a pilot, it wasn't powered to show anything like that. But I think what it really emphasizes that this is a complex patient population. We need multimodal interventions in order to support them. And this was successful in many ways, but we met challenges because of the diversity of our patient population in order to meet their needs in their different communities, being centralized in Hamilton. So lots of work, I think, that still needs to go on. And the next iteration of this is to start, in order to at least increase the number of patients we can enroll locally, is to move to other infections. So rather than focusing entirely on infectious endocarditis, which was a smaller subset of patients, we see lots of others that could benefit from this wraparound care. And so maybe any other type of infection is an access point. So the next iteration of this is called IRIS, and it's really for anybody that has an infectious related complication based in Hamilton.
Amazing.
That's everything that we had.
So it sounds like what you just described is actually just a really great inpatient addiction medicine consultation team, multidisciplinary, right, with the peer navigator,
Yeah.
the support, all that. So, I don't know. That's. I mean, the fact that when you said you were going to do it for other infections, I was like, yeah, that's kind of what we do as inpatient.
Yeah.
But I mean, am I to understand that the grant was finished, the study's done, and then everything kind of stopped?
Well, so the thing that this added in comparison to, so we didn't before this have peers engaged in our inpatient program. So that was a huge addition, and actually we have other ways we're adding peers in now. But we did follow them post-discharge. So all of the social navigator visits and many of the peer visits Marcy would have done, majority were done following up in the post-discharge space. So that was the add-on to what our inpatient service would have offered. Like usually our care would end at that time. But no, the plan, we're actually basically rolling all of this into the next iteration. It's another grant. And because we couldn't really make any grand claims with this pilot because of the low enrollment. So our hope is to get more people enrolled and see if we can monitor the impact of that to continue to make arguments for funding, basically.
We've started that pilot.
Huge differences in the hospital. We had our first support worker, our harm reduction specialist. I have a question about, did you look at differences, that's maybe not what you're doing, but did you look at differences between right and left-sided endocarditis, particularly with things like surgical interventions and occult?
We didn't, but we certainly could. It's an interest. Some of our, I don't think we've even reported on, because sometimes we see multivalvular as well, obviously. So we didn't, and with the small n, it would be hypothesis generating, but we absolutely could. It's an interesting point, and we've done a large program evaluation as well of the patients we've seen, but we didn't capture that nuance in that either.
And during that time, you said there was one person that died of complications of endocarditis. Did anybody die of an overdose?
No, not in this small cohort.
Yeah, more deaths from infections than from the toxic risk.
Correct. As far as we know from the follow-up that we have. Yes, yeah. During the data collection, yeah.
Community support prior to coming into the program, like through
Yeah, 20% were on OAT before they came in, so they would have had at least an outpatient opioid use disorder, like opioid agonist provider.
But as far as like systems nav and like peer support, it would just have been probably like street outreach in Hamilton and stuff, like through seeing them once in a while.
So if they were connected to a provider before and they wanted to maintain that provider relationship on discharge, that would have been maintained. So we didn't replace anything for somebody that was already connected with a provider, for example. The peer worker would have been supplemental. The systems navigator would have been supplemental on top of any of our street outreach work. And then the family physician, we only found them one if they didn't have one beforehand. So yeah, we just kind of basically looked at where are the gaps and where can we fill in on top.
And one thing we didn't include in here is, I want to say at least 5 of the patients have gone on to do peer support training and are doing community work, and 2 are applying to be part of like IRIS.
Ooh, with the next iteration, like if we were to, Marcy, anything?
I don't think so.
Yeah, I mean, we don't have like data linkage, so if we've lost a patient to follow up, we would lose data. So I wonder if that would be something that would
Maybe,
be
yeah.
supplemental, is if we could do some data linkage for those individuals so that we could potentially know about things like beyond in our study period where we were still following them, like longer term outcomes that might actually be supplemental. But from a resource perspective, I mean, houses in Hamilton
Yeah, that's what I was gonna say.
would be awesome.
Yeah, like I was gonna say sort of the same thing. There was a question in like another session I was at that's like, if resources weren't an issue, what would you want? And it'd be housing.
Yeah, roofs over heads would be probably the
If there was a
thing.
place for people to go, it would be wonderful.
It's a little outside the grant, but maybe not. Maybe like once we show this, we can build a hotel.
Be like, what is it like to be housed
On
after
display.
hospital discharge?
Yeah, exactly.
Yeah, so I did a presentation in Athens on the same thing, and a lot of that, the research coordinator, Alicia, was able to put in like some of the qualitative feedback from folks. So it is there. I think it's going to be going somewhere. I'm not
Yeah, there's
sure where.
qualitative interviews that were paired with this, but we just don't have them to present.
These aren't our slides. That I have to remember these. Just that people actually felt cared for, I think was the biggest thing, right? Like whether they're like, even if my health doesn't get better, I know someone sees me, was one of the quotes, right? Because they go into like, nothing against, again, healthcare professionals, but sometimes people who use substances or deprived of housing, or unfortunately both of those things at the same time, are treated differently in healthcare settings. And people that come in with physical health issues that don't necessarily want to change their substance use and just want support with their physical health are also looked at way differently, unfortunately. So I think having like someone like a peer support worker and a team that's just like, I'm not here to change you, I'm just here to be with you.
And anecdotally, we had a gap where we hadn't launched Iris and Second Heart had kind of come to a close, and people would be like, what, can I join Second Heart? Or people that, that had heard about it but didn't live in the catchment. So there was a little bit of movement that had happened where people would either come in and say, I'm part of Second Heart, or they'd say, why can't I be part of Second Heart? And so there certainly was a little bit of movement that was happening, which hopefully we can rebuild again with Iris because it's a new name. So yeah. We will. Thank you, everyone. Thanks for your time.
Yes.
Hi. Good. And just like it's spelled.
Well, usually it's a little bit of butchering, but I'm used to it.
Isn't sure.
You okay with that view? You okay with that? Or would you rather, I can put it in slideshow mode if you want.
Oh, perfect. And then this is the clicker?
Yeah, that's the clicker. It's right for right. If you go one too far, you can back it up. Okay.
Now for our final talk of the day, Tara Andrusiak is going to be talking about developing a framework for the admission and discharge process at Vancouver Coastal Health, and I'll let you take it away.
Great. Thank you to everyone for sticking around for my presentation, the last of the day. Oh,
See your face.
there we go.
Go this way. There you go.
I'm short. I'm Tara Andrusiak. I'm a primary care and addiction medicine physician in Vancouver, and today I'm going to be talking about some quality improvement work that I was a part of in looking to develop a framework for the admission and discharge process for support recovery and treatment sites contracted by Vancouver Coastal Health. So I don't have any conflicts of interest to declare. I start off with this slide showing the continuum of care. As a primary care and addiction medicine physician, I actually work in quite a variety of settings, which I find quite rewarding, and support recovery and treatment is one that I find particularly rewarding because we get to see people when they're moving beyond active, ongoing, regular substance use and moving more into the recovery stage of their journey. So I just wanted, I guess, to emphasize for everyone how important this is as a part of the process, and just, I guess, to comment that this talk's a little bit different than the preceding two that we had that were more focused on hospital-based care. So probably, as you all know, Vancouver is on the west side of our country, and Vancouver Coastal Health is one of the health authorities within that region. Vancouver Coastal Health has contracted a number of sites to provide support recovery and treatment to patients within Vancouver Coastal Health. So this means that these sites actually still exist as their own entity, but Vancouver Coastal Health is paying for beds in the site. So I won't go into all the details about this, but just suffice to say that sometimes the logistics in working as someone from the health authority, that being myself, with these sites can be a little bit challenging. Vancouver Coastal Health didn't always contract beds in these sites, so all of them have existed on their own in some capacity for a period of time. So the goal of this work was to look at trying to develop a framework or a process that would be universal amongst all of the sites to allow patients to move seamlessly into and out of the sites. So as you can imagine, this is a fairly large undertaking given how many sites there are. So we chose to start off with the Pacifica Treatment Facility, which I'll talk a little bit more about. It is the largest contracted site. It's also the site that I work at currently as the physician, so it was sort of a good fit for this initiation. So Pacifica is a treatment facility that was developed in the 70s. It's a co-ed facility. It has 30 treatment beds. The rooms are private, which a lot of patients find quite favorable or beneficial to them. It is also one of the only sites in the list that I showed previously that actually has Masters of Social Work clinical counselors providing both group and individual counseling. So that is one of the other, I guess, big draws to patients going to this site. In terms of other sort of complementary things that are provided for patients at the site, there is access to things such as acupuncture, massage, recreational therapy, music therapy. Patients are provided with their meals, so there's an on-site kitchen and kitchen staff that provides nutritious meals and snacks. In terms of the medical side of things, so there is a physician, that's myself, who provides coverage to the facility 1 day per week. On other days of the week, there are nurses that work for Vancouver Coastal Health that provide telehealth support as needed. So just to emphasize that on the site for the majority of the time, there are non-medical professionals working with these individuals. And this necessitated some of the need to look at some of the gaps in the processes by which patients were coming into Pacifica. So what were some issues that we identified were coming up both from our own perspective, but also in talking with the providers at the site and also patients? So one of the big things that we noticed was that with the process that was previously set up, patients would be coming into the facility and they might be using substances up until the moment that they entered the door, or they may have stopped using substances and were in active withdrawal. And because the site doesn't have 24/7 medical support, this would be a problem as withdrawal essentially can't be managed in this facility. We also noticed as the opiate crisis and just as addiction medicine in general has gone on over time, at least in my career, that in general patients have become increasingly complex. So often a patient would be admitted into a site and have complex wound care needs, complex mental health needs, and there just wasn't anything put into place to help support the patient in this. So what can we do to try to help this? As well, we were finding that patients were coming into the site with medication prescriptions that were inappropriate for support, recovery, and treatment. So this would include things such as needed benzodiazepines or safe supply opiate medications. So these were things that were coming up repeatedly and are often very difficult to manage if the patient's already in the front door. As well, patients would often come into the site and their expectations of what they were actually going to be getting from treatment were a little bit different from reality. So we were trying to look at a way, how are we going to address this problem? So we worked on some things through the quality improvement framework, and we did make some changes to how the process was. So essentially, all of the referrals would go through a central intake service through Vancouver Coastal Health, and these referrals would be referred by both a non-medical practitioner as well as a medical practitioner, this being a nurse. And the goal was to identify any issues or concerns that may come up either psychosocially or medically. To try to address the issues with more of the medical side of things, we had nurses assessing the patients 1 to 2 weeks prior to intake. As was listed on the previous slide, sometimes patients would be assessed when their application was put into treatment, but their situation may change by the time they actually were accepted into treatment 2 or 3 months down the line. So by having the nurse assess them 1 or 2 weeks prior, this would ensure that they were still ready to go to treatment. It also would allow for the patients to be connected to inpatient withdrawal management services that were provided through Vancouver Coastal Health. We as well got our pharmacist on board with this process, and he would get the referrals in advance, look at their medications, and see if there were any issues that might need to be addressed prior to intake. And then on the day of intake, the pharmacist would actually meet with the patient via phone and go through their medications and do a medication reconciliation. I highlight this because typically on the day of intake, the whole intake process is being done by a non-medical person. As I mentioned, I'm the physician on site. I'm only there 1 day per week, so usually intakes are coming, all of the days that I'm not necessarily there. So we were training our non-medical colleagues at Pacifica to recognize things that might be problematic for the patient in terms of substance use and withdrawal when they were doing their intake assessment. And because the nursing team was accessible by phone 24/7, this allowed for the staff at Pacifica to contact them and try to get patients into the appropriate setting sooner rather than later. So there's a few more things that we're currently working on. One specific to Pacifica is that they're developing a program-specific pre-engagement process where patients actually will go through different groups, go to the site, do tours, and this is really to address the issues related to patients not really knowing what they're going to be getting when they get there. We're also looking, hopefully in the future, to have a single pharmacy supporting the different Vancouver Coastal Health support recovery and treatment sites. Right now, because all of the sites are contracted facilities, they all have their own pharmacy provider. So it's difficult to develop standardized processes because we're having to talk to all of these different individuals and set up relationships and procedures. As well, because all of these sites were at one point standalone, they all have their own processes for things like over-the-counter medications. So we've been working to develop a standardized over-the-counter medication form so that it's easier to get the patients medications they need, like Tylenol, ibuprofen, etc. One thing that does come up on occasion is that patients do need controlled medications more than once per day. So I'm not sure how many people work in support recovery and treatment facilities in their communities, but typically the pharmacist may come in once per day to provide medications. And then for the remainder of the day, the medications are on site for non-medical professionals to administer. So this places limitations on the ability for a person to receive more than once per day medications like benzodiazepines or opiates if that is something that's necessary. So we've developed this process with lock boxes where patients can actually administer medications themselves as appropriate. And so that this gets around the fact that they're not going to have a pharmacist or a nurse on site 24/7 to provide these medications. So I'll talk a little bit now about some of the issues that come up with the discharge process at support recovery and treatment. One thing is when discharges occur when they're not planned. So when this happens, oftentimes it's hard to know where does the patient want their medications to go, or even where does the patient themselves go. So sometimes they'll want to leave precipitously for a variety of reasons, and the team is scrambling. It always happens to be on a Friday afternoon or Saturday morning, so there's not a lot of extra support. As well, it's been challenging to find a good way to communicate between the sites and the community teams. So that's a gap that we've identified that we're still currently working on. And then lastly, one of the big gaps that we are still trying to work on is trying to connect patients with community providers once they leave Pacifica. So a lot of patients will come into Pacifica. A lot of them are actually connected with addiction medicine providers, which is great, but they don't actually have any connection to primary care, and it's very challenging to find them someone to connect to in the community after we've started to work on some of their primary care needs while at the facility. So some of the things that we've worked on to make this a little bit better thus far is ensuring that there is a standardized process for documenting and reviewing what the patient's discharge plan is. And this is reviewed by the team on intake, as well as monthly to ensure that it's updated in case a patient is to leave precipitously. As well, if a patient is to leave all of a sudden without planning, the team notifies both myself, the nursing team, as well as the pharmacist. So this allows us to make sure that patients do get their medications sent to their community providers so that there's not interruptions in crucial medications, OAT, benzodiazepines, or even their primary care medications like antihypertensives or SSRIs. I'll note, and this is something we've been doing all along, that if a patient does discharge in a planned manner, that they will meet with me, with the physician prior to discharge, and we will go over what their discharge plan is, where they're going, who their community provider is, and ensure that they have prescription medications and appointments set up prior to leaving, and that the patient will be written up a discharge summary that they can provide to their community team. So I mentioned some of these things before, but we still need to work to make sure that we do have discharge plans in place. One of the things I think some of the other groups have mentioned is that we don't really have sometimes places for people to go. So if someone leaves precipitously, they don't have stable housing, they don't have a friend, they don't have family, where do they go? And we struggle sometimes to figure out a safe space for them to go, especially if it's a situation where the patient either wants to leave or has to leave very urgently. We're still trying to establish connections with community primary care providers to ensure that patients do have primary care when they leave treatment. And then lastly, we're still struggling sometimes to make sure that the information that we do create in terms of the discharge documentation is actually disseminated amongst the different community teams. So this has led to some work in trying to establish a standardized discharge template and process for the discharge summaries to be sent out. So thank you for everyone's attention, and I just wanted to thank both Pacifica and Vancouver Coastal Health for their work in this project, and I will leave it to any questions that anyone may have. Yep. That's okay. Yeah, so it's a little bit different amongst the different sites that I listed up here. Let me just go back. But I know for Pacifica, it's usually about 6 months. Sometimes people will get in a little bit sooner, depending on what's going on. For some of the other sites, like I think for Emerge, it's about 2 months right now. So it really depends on the facility. But of all of these sites, they all have different, I guess, features or idiosyncrasy. So as I mentioned, Pacifica is co-ed. Everybody has their own room. It's also one of the only facilities on this list that is accessible. So it has an elevator, so people in wheelchairs can use it. And it's also one of the only sites right now that accepts patients on the fentanyl patch. So yeah, the wait list I think is influenced a lot by some of those things. Whereas the other sites, like Emerge, for example, is a men's only treatment facility with shared rooms and not accepting patients right now on fentanyl patches. So they're all funded beds, yeah. You said you had a second question? Or? Okay. Any other question? Yeah.
That you would have a centralized referral form for all of them, and then you guys would kind of triage based on the individual's needs, or is it always that they apply to?
So there is a centralized form that's been established, but there still is a lot of things that happen when a referral goes to a site that's sort of decentralized. So I think what the goal is having both a centralized form, but also a centralized process so that, one site's not deciding they won't accept a patient for reasons that aren't really evidence-based. Yep. So I think what we're, I guess, envisioning is probably a lot of the information will be collected by the healthcare workers at the sites because there's more person power. So having information like who's their community provider, what's their preferred community pharmacy, where is the site that they're going, maybe getting information such as, they seem like minor things, but fax information, that sort of stuff, because often when that information isn't there, because there is quite a lack of resources for this sort of process in general, things just don't get done. They kind of, not intentionally, I don't think, but if a piece of information is not there, then someone might just not have time to look into it further and it kind of gets dropped. But I think from a medical side of things, we would like to develop a standardized template that can be maybe filled out by both the nurse and the physician as a shared team over time that lists different things that have happened with the patient while in treatment and like a short summary of what the outcome is. Because right now, the discharge summary falls all to the physician at the end of their stay. And sometimes that could be a lot of things to put in and a lot of extra work to do just at the time of discharge, particularly if it's unplanned and you don't have that time set aside. Yep.
Quick question about, you mentioned throughout the presentation about community teams. Was that just like their inpatient provider, like OAT provider, or like, is there something additional to the community team that would be getting that information?
It sort of depends on the patient. Like some patients are followed by community primary care clinics that have, I guess, a team-based approach where they have like social workers, psychiatrists, other allied health support. We do have different, I guess, teams that help high-risk populations like the overdose outreach team or I'm blanking on the name now, but the team that follows patients with unmanaged HIV. So hoping that all of those teams that are involved in the wraparound care of the patients would get this information. But it is very patient dependent. Some patients will come in and they're not connected to anyone, and they might have presented to a rapid access addiction clinic and been referred through that means, or they might have been referred while they were at detox. So. Any other questions? Oh, yeah. I believe they're in the same process, but my understanding is typically a patient wouldn't be put into a transitional bed without a viable plan that will come to fruition in the amount of time that they can stay in that transitional bed. So it's a little bit confusing, but there's actually transitional beds at Pacifica as well. They're called stabilization beds. So every so often a patient will be in a stabilization bed at Pacifica, not actively participating in treatment, and then will transition over to treatment. So they might actually be at Pacifica for 6 months, but they wouldn't be put in that transitional bed at Pacifica unless there was somewhere that was thought to be a feasible option for them to go to within the first 3 months of their stay. Any other questions? All right, well, thank you.
So I'd like to thank all the speakers for being for excellent talks, and I found them all very inspiring. I want to thank all of you for being here, and I want to thank the tech support because they actually make this all happen, and they're in the background and nobody thanks them. And I also want to welcome everybody to the reception at the Sheraton Hotel Ballroom. So it's not in this building. You can walk across. There's a walkway across. This building will actually be locked at 6 o'clock. So make sure you have everything out of here by 6. And hope you all enjoy the reception this evening. Thank you.